So we are at our first all virtual management forum. Really want to thank you for joining. We don't have Joint Commission today, so that gives us a little bit of breathing room for our management forum. And I want to thank Christina Padilla and Brent Andrew for putting this together. We may have a few bumps in the road, but that's to be expected, and we will learn and do it better the next time. So we have a very busy agenda today. I think what we'll try to do is have you put your questions in the chat, and then we will make sure to get to them all at the end. And we're going to start with Basil Price, our Director of Security for the Department of Public Health. Thank you, Basil. Take it away.
Thank you, Susan. So I'm going to talk about the threat management and workplace violence prevention plan. And so if you could pull up the first slide, please. Next slide. Thank you. So we have a policy that says that we have a zero tolerance for violence, bullying, and threats and intimidation. And what my experience has been is that this is a policy that's in writing. However, we have been tolerating workplace violence, intimidation, and bullying from our employees, from our coworkers, from patients, from everyone, visitors as well. And so the purpose behind this presentation is to give you information as far as what to report, when to report, and what happens when you report an incident of threat as well as workplace violence. This is a plan that's been in place since 2017. And with that, even though we have 135 active cases of people that we monitor that have posed threats to the hospital, we know that there are many more incidents of threats and acts of violence that go unreported. And so what we want to do is to give you information again on when to report anything that affects the hospital or occurs on hospital premises. Not every issue occurs on the hospital premises that becomes an actual threat or threat management situation. Some of these incidents actually start on social media. They start in people's personal lives with family members and other relationships, and it has a tendency to spill over into the workplace. And so we get involved in those type of investigations as well. Next slide. So one of the first things I want to talk about is bullying behavior. Here are some examples of bullying behavior. This applies to every person in every position. Normally, bullying is one of those issues that provokes angry employees or even patient and visitors to the place where they escalate to some threat or act of violence. With the first bullet where it talks about spreading malicious rumors, gossips, and offensive jokes. Doesn't necessarily have to be verbal. Some of these incidents occur through email and again through social media. And so again, just an example of bullying behavior and how it escalates to some higher degree of threats or workplace violence. Next slide. So as I said before, this is a process that's been in place since 2017. And I want to just give some examples of some of the type of incidents that we've dealt with and what the outcomes were. July 2017, again, here's an example of off-site that has an impact on the hospital where individual stalking his girlfriend who was a hospital employee, armed with a firearm. This individual was actually arrested. October 2018, there's a situation where employee against another employee, communication of death threats. We learned that this individual employee actually had a firearm inside of their vehicle. We were able to get a restraining order against this particular person, as well as for the safety of the victim employee, transfer them to another location. September 2018, this is harassment, intimidation, and bullying from an employee to a manager that resulted in a termination. March 2019. This is a repeated patterns of harassment as well as unwanted touching by a hospital visitor against several employees. Working with the threat management team of UC and the city attorney's office, we were able to get a restraining order against this particular individual. Next slide. April 2019, hospital patient discharged with threats of violence. In this case, was the individual was arrested January 2020. This is hospital direct angry outbursts from a patient against an employee. A behavioral agreement was set up for that particular instance. An employee-on-employee battery that resulted in injury. There was disciplinary action taken. And then there's an employee against employee sexual battery where there was disciplinary action. The whole point of these scenarios is to help you to see that we're not just receiving these reports and documenting. There's an actual threat management process that includes investigating, determining a risk level, and then coming up with a plan, a security plan as far as how we're going to protect the victims as well as address the threat. And that's the importance of me highlighting some of these type of incidents, which are the more severe, as well as giving what the outcomes was what action we actually took. Next slide. Reacting to a threat, one of the things that's really important is that we learn about this information as soon as possible. Time is of the essence. We want to treat any type of threat as if this person plans to carry it out. They may not do anything that particular day or next day or weeks or even months, but what we know about threat escalation is that over time, depending upon the circumstance, this person will continue to think about it, go to a plan and planning, gathering the tools necessary to carry out this threat before they actually execute it. And so anything that you observe, whether it be in the hospital, outside of the hospital, or impacts the hospital in any type of way, involves anyone, whether they're employee, contractor, or receiving services, we want to hear about that incident, know about it as soon as possible. In any cases, especially when it involves patients, part of that threat assessment includes interviewing all impacted staff to include the individual that made the threat. In a lot of cases with patients, we lose communication once that person leaves, and they have valuable information to help us, again, assess the level of threat. Not everyone has a contact information or address where we can actually reach out and get their side of the story so that they can provide context in that situation. And so as soon as you hear about it or know about it, it's really important to get threat management involved. That can be, you can call me directly, send me an email. The UO system is a good tool, but when we're dealing with timing, we want to address these issues immediately after they occur. If it's a situation that actually involves the imminent threat or where there could be death to a person or persons, then of course you want to call 911 or the sheriff's office here on campus. Next slide. So some of the things that you want to report, of course, there's threats. Here's a list of things you report. It's not an exhaustive list. Not every threat has to do with words. Some threats involve gestures. There are threats that involve symbols. For example, there was an incident that I investigated involving an employee. This particular employee had figurines on their desk which were of a violent nature. Was disturbing to some of the staff. We end up doing that as a threat investigation assessment as well. You have other situations where the threat may not be verbal, but going back to the bullying, sometimes bullying can be so traumatic that that person's mere presence actually is threatening to an individual. And so we want to hear about that as well so that we can investigate that incident also. Intimidation. This involves invading a person's personal space. Each one of us has personal space. It just varies depending on the individual. So once you feel threatened by the fact that someone invaded your personal space, which is exactly what it is, then that's considered a threat Those are the type of things you want to report as well. Bottom line, as I said, this is not an exhaustive list. Anytime you believe that your personal safety is at risk or the safety of others, we want you to report that incident. Next slide. We have a threat management team. We meet every fourth Tuesday to discuss the cases and any updates on any of our other 135 cases. The list here, 1 through 6, involves the threat management team under the ZSFG administration. That would also include UC administration. And as I said before, in addition to DPH's or the hospital's threat management team, UC also has a threat management team. And so when these incidents involve UC employees or impact them, we do work and collaborate with UC's threat management team to address them as well. We also have support from our information officer, employee assistants, as well as the city attorney's office. There's a liability clock that begins anytime a city employee has been threatened. And so part of that threat management assessment is to actually work with the city attorney's office, determine whether there's sufficient information to convince a judge to provide or issue a workplace violence restraining order. And so what that entails is that one of the questions in the threat assessment interview would be, are you concerned for your safety? And if you're interested in pursuing a restraining order. And as you see from the scenarios that I shared, we have been successful in doing that when it became necessary. That individual person would have to give a declaration to the city attorney's office. There would be a court date. At some point, they would have to testify. The individual that communicated the threat or act of violence would also be present to give their defense. And then again, ultimately, it's the judge that makes that decision on either a 3 to 5 year workplace violence restraining order. Next slide. This flow chart just describes the whole process. Anytime there's a threat or act of violence that has been reported, the department manager has a role with regards to gathering information. They should be the one making the first contact or interview to gather this information if it involves employees or patients. Usually threat management, I'll get involved in an incident, and if there hasn't been any communication with, for example, a patient from the manager, willing to do so, but what I find out with my interview is that this is more of a service recovery issue where you have someone who's just dissatisfied with their service. They probably said some things just out of frustration with our processes, but they really didn't reach the level that it should have been treated as a threat management situation. So it's really important that the manager be the first to engage those employees as well as engage patients if they're the ones that are part of this particular incident. That information should be documented, and then at that point, they turn it over to myself, and I work with the threat management team in the sheriff's office. Again, we determine the risk level, and we come up with a security plan as far as how we're going to protect the victims, address the threat, and protect the organization. Next slide. There's 3 levels of risk when it comes down to the assessment. During a low risk investigation, we determine that there's reason to believe that this situation has been de-escalated and it will not escalate to a higher level of aggression. With moderate risk, there needs to be some specific remedial action or else this could escalate. And then high risk when we determine that there is imminent danger for injury or death to one or more persons. We want to come up with a plan with this. Usually in those interviews, because this doesn't necessarily have to be that the employee or the patient or whomever committed the threat or act of violence is the one who's at this level of risk. We look at the situation within its entirety. For example, one of the questions that we would ask in an interview is, who knows about this incident? Who have you shared? Have you talked to your family about it? What has been their response? Because what we've learned is that For example, with an employee, the employee may not be the person that is a risk to the workplace, but based on family members who are upset by how their loved one is being treated at work, we need to understand that as well, because those individuals have a way of coming into the workplace and posing again a threat to the workplace. It was all part of the process of what we learn from these incidents to determine that risk level. So that concludes the PowerPoint, and at whatever point we'll be open to answer any questions. Thank you.
Thank you so much, Basil. I have such deep appreciation for you and the work that you do to keep us all safe in so many different ways. And so I just want to ask everybody on this call to help Basil and help us help all of the rest of us on this campus. So really appreciate all that detailed information, Basil. And I think any questions or other information we'll get to at the end, because I want to keep moving through the agenda. Next, I'm going to turn it over to Terry Saltz, and he will talk with us about Capital on campus. Thanks, Terry.
Hi. I think you can see me now, I believe. This is a new format. Trying it out for the first time.
We can see you.
You can't see me.
We can see you.
Oh, okay, great. Thank you. Starting this out, this is the capital programs update. I have some good news to report on project progress. Our poison control space on the second floor has been built out. We've gotten occupancy from Oshpod, and we've installed furniture, and we're planning to move now for poison control to relocate to that location. The next project is that's up for occupancy is the 6H surge space. We're planning for occupancy in April. We're working through some mechanical and fire alarm issues up on that floor, and we hope to gain occupancy from Oshpod in April. Our rehab department is coming along. Some areas have already gotten limited occupancy, and we're punching through it. That's a punch list where we go through and we look for problems with the build, and we make corrections before we actually start occupying the space. But rehab is scheduled to be going through their occupancy and their last inspections with Oshpod in April as well. Transition planning is underway with rehab, and we hope to get a schedule for when we actually do the relocation. But transition will include facility fit up, licensing, training, and orientation. So there's a lot of things that have to be done before we actually make the move from the basement to the third floor. So that's exciting news. And of course, what's great about the rehab relocation is that opens up space in the basement for us to begin our public health lab construction, which is currently out to bid with some other projects. And so we hope to get contractors identified and get that project underway right on the heels of relocating the rehab departments from the basements. Another project that's out to bid is the dialysis project. And that will occur also as soon as the rehab project is completed. So it's pretty exciting to get the rehab done, because that really opens up the door for multiple other projects to get underway. And as anybody knows, both those locations, the public health lab, which is located at 101 Grove, that's the city public health lab, and then the dialysis unit in Building 100 is one of our oldest buildings. It's due for a relocation, so we're excited about getting that underway. Another project that's out to bid right now is the seismic project. As I have reported before, the seismic project is going to start in the pharmacy, and it's going to work its way up the building, and there will also be some work around the building. There'll be, once we have the contractors that will be doing that work identified, we'll be producing a schedule for everybody to be aware of what's in store. Again, who's seismic going to impact? It's going to impact everybody. So following the bids that are out right now on dialysis, public health lab, and the seismic project, The next one next month will be the Flynn Lab project, which is on the second floor in the Flynn Lab. It's the track replacement project. That construction is going to coincide with the work in the pharmacy seismic, so we can kill two birds with one stone there. And then following the Flynn Lab bid, we'll have the IT infrastructure bid, and that's going to be building new, up-to-date data closets throughout the building with mechanical upgrades and electrical upgrades to go along with it. Other projects that are being worked on in design is a fire alarm replacement project, chiller replacement project, family health center, and building 8090 specialties relocation. So those are underway. That completes the Zuckerberg updates. I have to ask, is the next up is the UCSF's report on the research facility. Is there somebody from UCSF on the line for that? I'm seeing.
I don't think so, Terry.
I don't think so, Terry. Okay, so what's in store with then I'll take the mantle then. So I'm looking out my window and I'm seeing the construction site. This is the benefit of doing it from your office. They have poured the concrete foundation. It's looking, the progress is pretty impressive. They're coming along very nicely. The foundation, pot knuckle pallets have been completed and the foundation pad is there. The next big event is steel erection. So what we will be seeing towards the end of this month, we'll start seeing steel brought to the site and some tower cranes brought, and they'll start erecting the structure. That steel construction is scheduled to go on through May. So we'll have about 3 months of steel construction, and it will be a noisy period. We will be providing the standard noise abatement earplugs and ear muffs and ways for people to continue doing business with the noise that will be occurring. We could also make available if you find yourself in a situation where you are on the phone a lot. We do the telecommunications department does have a small inventory of headphones with a mic that are sound canceling. Those should be used sparingly. They are heavy units and they get hot, but they do allow you to have a conversation. So that's a good thing about that. So the big, there's other utility work that the RAB building is, or the research building is finalizing. They are working on the pedestrian walkway along the driveway this week into next week, as well as doing roadway improvements. I will point out that the roadway portion of the project will be delivered to the hospital first. Hopefully early summer, we'll have access to that roadway while the building construction continues. And I think that's what I have for the UCSF project. And that concludes the capital programs update.
Great, thank you, Terry. I so appreciate all the work you and your team do to keep our facilities functional and make them beautiful. So really appreciate that. Next up on our agenda is Catherine Argumedo. She's our Privacy and Compliance Officer, and she has some updates for us. Take it away, Catherine. Thanks.
Okay, thank you very much. Hello, everyone. Good morning. My name is Catherine Argumedo, and I just wanted to take a couple minutes today to review some privacy reminders. The slides that I'm going to be presenting will be shared, and I ask that you share them with your staff. This first one, it really has to do with a little kind of snippet of all of the different types of protections that we want to make sure that are going on with PHI at our facility. The first has to do with protecting hard copies. So if you're ever having anything on your person, we want to make sure that you're not taking any documents containing PHI off campus, or if you are, that they are secure, preferably on an encrypted device and with you at all times. If you are going to mail something, we would like you to, double check the address, recipient, and make sure that whatever is going in the envelope is corresponds to the envelope that you're putting it into. The next item has to do with encrypted devices. Please check with IT to make sure that any devices you have, a laptop or your phone or any flash drives, are encrypted. And also when you're sending emails, using your DPH email address, and if you put the word secure in the subject line, it will encrypt that email. Please do not put any identifying information in subject lines, which includes patient initials. And if you are sending any sort of confidential information, please make sure to de-identify as much as possible and take out whatever is not actually necessary for the person that you're sending it to or people that you're sending it to. The next item has to do with faxing, and similarly to mailing, make sure that the fax number that you have is correct and the recipient is correct before you transmit. Please use a cover sheet with a confidentiality statement and always send just the minimum necessary. And the next item has to do with shredding. So if you do have hard copies or any paper documents with PHI and if they're not of any use and they don't need to be maintained anymore, please make sure to dispose of them in the shredder bins, not in any sort of recycling bin or trash bin. It is important that you just put it in the shredder bin. It's very important to do that. And then if there have any questions or you're concerned about something, you're not sure if maybe there's been a breach of patient privacy, please make sure to contact me or my office. My phone number is there on at the bottom of this page, and my email address is my name, Catherine.argumetto@sfdph.org. So please feel free to reach out. The last reminder I just wanted to provide for today is on the next slide, and it has to do with accessing your own personal record through Epic. Right now, there are a lot of people that have a newly created DPH Epic record, and it's important that if you're trying to access any test results or anything having to do with your own record, to please use MyChart and not access Epic through your regular provider account. And it should be fairly seamless to set up your MyChart. I did it myself and I found it to be quite easy. But if there are any issues, there's a number there for an HIM. They're able to help. But you should be able to get an access code fairly simply and be able to access it really well and quickly. That's sort of all that I really wanted to cover for today. I just wanted to keep it kind of short. But if you have any questions, I'm happy to participate in any huddles or attend any staff meetings for people if there are questions or if there's something specific that your area would like me to cover, I'm happy to do that. And I just want to thank you for your continued efforts in protecting our patients' privacy. So thank you very much.
Thank you so much, Catherine. These are often neglected details, and just want to thank you for reminding us all how we can keep things safe and confidential. Okay, great. So just want to remind everybody to put their questions in the Q&A section, and we will get to them at the end. And now I want to turn it over to Dr. Lisa Winston, our Chief of Infectious Diseases, and just for the COVID update. Thank you.
Thanks so much, Susan. I'm actually not our Chief of Infectious Diseases.
Sorry.
No, that's okay.
I think of you that way. Sorry about that.
But I am the medical director for infection control and one of our infectious disease physicians, and delighted to be with everyone again to give you a bit of an update about COVID. So there's always so many things that we can talk about, and I thought it might be timely to talk about 3 things today. One is just to talk a little bit about the epidemiology of where we are with COVID, especially with respect to vaccinations and administration. Then, because it's been in the news quite a bit, review the Johnson & Johnson vaccine briefly. And then finally, talk about the new guidance from the CDC about requirements for social distancing and mask wearing for fully vaccinated people. So to start first with a little bit of the epidemiology and vaccine administration, I think as everyone is aware, the data for the US are really sobering. We've had almost 29 million cases of COVID that have been diagnosed in the US, and many more that have not been diagnosed. And a little while ago, we passed the grim milestone of more than 500,000 deaths. We're up to almost 524,000 deaths from COVID since this started. But in, kind of in the context of that sobering news, we are starting to see decreases in COVID cases in many places. And San Francisco is looking good. We are very happy that we have only had 7 patients in the hospital for the last few days without any new cases being admitted over the last couple of days. So while COVID cases are plateauing in some places in the US, we are encouraged for how things are looking locally and also for our own vaccine efforts. So just to give some context with where we are with vaccines, and I was just looking this up because these websites are updated very frequently, but in the US as a whole, about 23.5% of the population over the age of 18 has been vaccinated with at least 1 dose, with 12.3% fully vaccinated. And that's not bad, but when you look at the over 65 numbers, I think they are something really to cheer about. So across the US, over age 65, 59% of people have had 1 dose and 30% are fully vaccinated. And we're doing just slightly better than that in San Francisco. Our total numbers, these are over 16 rather than over age 18, but we're 25% with 1 dose, 12% with 2 doses fully vaccinated. But then over age 65, a whopping 68% of our San Francisco residents have received at least 1 dose of the vaccine, and 35% have received 2 doses. So that may be one of the things that is impacting our hospitalizations because, of course, age is probably our most potent risk factor for severe disease and hospitalization. So good news on that front. Many people may also be aware that we are now giving over 2 million doses a day across the US in terms of the vaccine rollout. So pretty robust across most places, including here. And a lot of those numbers get reported locally in our daily digest in terms of staff and patient vaccinations. So moving from the epidemiology, I just wanted to say a few words about the Johnson & Johnson vaccine. You may also hear this referred to as the J&J vaccine or the Janssen vaccine. They are all the same. And this is the first single dose vaccine that has come through and gotten emergency use authorization in the US. It's a different technology from our 2 other vaccines that have emergency use authorization, Moderna and Pfizer. So Moderna and Pfizer are mRNA vaccines. The J&J vaccine is an adenovirus non-replicating vector vaccine. Actually, once the DNA gets into the cell from the J&J vaccine, it works very much like the mRNA vaccines. And your cells that present the viral antigens to the immune system, go ahead and put those antigens up on the surface with all the different types of vaccines, and you get a very nice and robust immune response. So there are certain very distinct advantages with the J&J vaccine compared to the mRNA vaccine. Firstly, it was studied in its major clinical trial as a single dose. So the data, the very nice data that we have to date are from just one dose of the vaccine. It's somewhat less reactogenic than the other vaccines, so people tend to have fewer and more mild side effects. And it's much easier to administer because it doesn't need to be frozen and thawed and reconstituted like the other vaccines. It comes in a refrigerated vial, and so it's more amenable for mobile distribution and getting it out to places where it may be harder to administer the other vaccines. The other really nice thing about all of our vaccines is that they have very, very high efficacy against severe disease leading to hospitalization or death. And in fact, in the Johnson & Johnson trial, when you look at 28 days after receipt of the vaccine, there were no hospitalizations and no deaths in the people who were vaccinated. Now, no vaccine is perfect. So I think some people may have heard that one of the concerns about the J&J vaccine is that it is not quite as effective as our mRNA vaccines against more mild disease, at least in the way that it was studied. So, it was studied over a different time frame, and it was studied internationally. So it is possible that some of the variants may have been affecting the virus's ability to combat more mild disease, even though even in South Africa with the very concerning variant, it was still very protective against severe disease. The other thing that I think is worth keeping in mind about the J&J vaccine is that its ability to prevent mild and moderate disease was based on single dose, and it is now being studied as a 2-dose vaccine. So even as we start giving this vaccine and people are celebrating, yay, I got my 1 dose, I'm fully vaccinated, we probably should keep in mind that as we learn more about this vaccine, it's possible that at some point in the future, it may make sense for people who've gotten 1 dose to get a 2nd dose. But that could happen with all of us, regardless of which vaccine we've gotten, because there are studies going on with all the vaccines now to try to update them to be more effective against variant viruses. So lots going on. The Advisory Committee on Immunization Practices and the CDC does not prefer any vaccine over another vaccine for any particular population, and is really recommending that people get whatever vaccine is available to them, moving towards more rapid protection of both individuals and the population as a whole. All right, and then the last thing that I will mention is the new CDC guidance. And if anybody wants to read this guidance themselves, and actually it's not too bad, it's only about, if you scroll through it or you decided to print it, it's only about 5 pages long. But if you go to cdc.gov, it's the very first thing that comes up under their top banner of what is new. And this basically is new recommendations for fully vaccinated people. And, I personally just kind of want to applaud the CDC for coming out with what I think is a very honest statement about, kind of what we know and what we don't know, and acknowledging that people really do need something hopeful about what they can do, as opposed to things that you must refrain from doing. And there's a very nice scientific statement that's linked that goes through all the data that their recommendation is based on. But in a nutshell, what they say is that fully vaccinated people outside of the workplace. So I'll just point out that this guidance really is not about the workplace, and it specifically is not about healthcare settings like our healthcare setting. But they describe scenarios where fully vaccinated people who want to get together with other fully vaccinated people in their own homes in very small gatherings, and they describe a couple who might want to have dinner with their fully vaccinated neighbors inside without wearing masks. If everybody's fully vaccinated, that would be low risk. They also describe, and the scenario that's used is fully vaccinated grandparents visiting their non-vaccinated children and grandchildren in one household, that it would be low risk for those people to get together. So long as they're none of the younger folks, the children or the grandchildren who haven't been vaccinated have high risk for disease. But they still recommend that medium and large gatherings be done in a fully socially distanced manner, wearing masks, being outside where feasible, and that masks be worn in public spaces even when people are fully vaccinated. They also make a commitment that they will update the guidance as more information becomes available. So what I would say is that it is not yet terribly applicable to our own healthcare environment. But our local public health folks are working on some updated guidance. We are meeting and discussing it, and we'll also be discussing it with our colleagues at UCSF. So stay tuned. And in the meantime, if people do want to have staff meetings or other small gatherings together in person, if everybody is wearing masks and can be appropriately distanced from each other, we do think that those kinds of meetings are safe. But we're not yet ready to take off our masks here in the workplace environment. I will stop there. I may have gone over time, and thank you very much.
As always, Lisa, thank you so much for that great information. There's some questions in the chat that are going to be for you. So if you don't mind holding for a minute, I'm going to turn it over to Val Barnett, who is going to talk to us about disposing of masks and gloves, and then we'll get to all the questions and answers. And please, if you have them, put them in the Q&A section. Thanks, Val. Go ahead, and thank you, Lisa.
Okay. Hi, everyone. Thank you, Susan. So today, I am going to be talking to you on behalf of the Environment of Care Committee. I do have a couple of slides, if Christina can pull them up for me, please. Thank you, Christina. Okay, next slide. So as we are working towards Joint Commission preparedness, they didn't come today, so that just means that we have more time to prepare. I'm actually going to be talking to you today about two things that have become really important issues on campus. So number one, properly disposing of your standard waste. Examples of this are shoe coverings, gloves, and disposable gowns that are not saturated with blood. They need to go in a trash can. The urgent request on behalf of the Environment of Care Committee is to please place those items in a trash bin during your doffing process prior to leaving the site of care. So it actually is all the way at the bottom. I made it really small, but it's the Infection Control and Prevention Policy 7.1. If anyone is confused around waste streams or when to dispose of certain waste, please refer to that policy. It's really important from a cross-contamination perspective and a littering perspective. If you go in the back of building 5 by the loading dock, that's where the biggest area is, that staff parking. We have a lot of people disposing of gloves, shoe coverings, and things of that nature in that area, and they belong in a trash can. But further and beyond that, they should be disposed of prior to leaving the site of care. So if you're seeing a patient on the 4th floor, when you leave that patient's room, that is the place where you need to dispose of those items. So we need to uphold our regulatory standards, and we need to be very respectful of our neighbors. We do get a lot of calls from the neighbors when we have a lot of littering outside. It is a big frustration point, as it should be. So in addition to us being courteous to our neighbors, we just need to be very kind to the environment as well. Next slide. Okay, the other issue, no smoking on campus. This has been a topic of the EOC newsletter. This is a hospital-based requirement. It applies to all personnel, visitors, patients, and contractors. So the Environment of Care's urgent request is to please lead by example. We do ask patients not to smoke on campus, patients and visitors, excuse me. But we have to lead by example, because if visitors see the staff smoking on campus, it becomes very difficult to tell them not to smoke on campus. So the entire campus is a smoke-free campus, the entire campus. Be cautious about smoking on or near private property. Again, we do have neighbors. Some of our neighbors do not appreciate people smoking on their property. So just be very cautious of that. Properly dispose of all cigarette butts. When the Joint Commission comes on site to do a survey, they oftentimes will walk the campus to look for evidence of smoking to see if we're upholding our non-smoking campus requirement. So first and foremost, put it out. We don't want to start fires in the trash can. And second of all, please dispose of it in a trash bin, not on the ground. What is prohibited and why? This is another point. All smoking types. So traditional cigarettes, vapes, electronic cigarettes, all of those things are strictly prohibited on campus. And it's important to remember that. It's for regulatory compliance and the health of everyone on campus. And for anyone who wants to look at the standard, the Joint Commission actually created a totally separate standard that requires hospital facilities to be non-smoking. And it is the Joint Commission standard EOC 2.01.03. And you can access that standard through the intranet. There's this little tool that quality department uploaded where you can look at all Joint Commission standards if you want more details. And it's actually a really cool feature. So again, let us please be good stewards, be kind to the environment. Let's be kind to and cautious to our neighbors. And most importantly, properly dispose of your waste, and please do not smoke on campus. And that is the end of my presentation. Thank you.
Val, thank you so much for those really important reminders. And I really appreciate all of you out there helping us keep the campus clean and, you know, just do what we can to make sure it looks good and is an inviting and welcoming place for every single person who comes on campus. Okay, thanks, Val. All right, we got some questions. Thank you all for putting these questions up there. I'm gonna turn it over to Brent for a minute. I know, Brent, you had some questions, and I want to hear what they are, and then we'll get to the other ones here.
Okay. The first question actually comes to Basil. Basil, can you give us a sense of how big the problem is of workplace violence and whether the data reflects the kind of accurate picture or whether we have a broader picture than the data itself suggests?
Well, taking the workplace violence for last year, there were 300 incidents, and that was an improvement from the year previously. Not sure what the actual numbers are thus far, but when you compare that to comparable facilities, for example, Alameda Health, last year they were 500 workplace violence incidents. And so we have a lot of work to do as far as reporting of these incidents. There's been improvement, but they're still underreported.
Okay. Could you also, and this comes from the Q&A online, how do you interface or work with HR during these incidents?
Sure. HR is a part of the threat management team. So anytime there's an incident that involves employees, whether they're communicating the threat or victims, I'm working with HR. Usually we will joint interview certain employees depending on the situation, or they'll coordinate for me to make contact with that employee. So they're an active part of the process.
And I just
And
want to
you-
mention that this not only involves DPH HR, but also UCSF HR. We actively work with both organizations.
Okay, thank you. So let's jump back to Lisa. When will we start to know a difference in our practice, let's say relative to our use of PPE on campus?
Well, I think we have already made some small changes to the use of PPE on campus. For example, no longer reusing gowns for COVID patients as our numbers have gone down and our supplies have gone up. I think that we will probably start to see some small and incremental changes with PPE going forward. We may be able to, do some things with eye protection, for example. But I don't actually think we are going to have major changes in terms of our masking for a while yet, till we see where things are going. I think we're probably at a fairly stable place in terms of PPE. I do think we're going to be able to have some relaxations going forward, though, in terms of how staff interact with each other. But I think it will be important for us to get public health guidance and more information before we do that. But I think that's probably going to happen before changes in PPE.
Yeah, and just to say, I really appreciate Lisa and Elaine and Vivek work very closely with the command center, with our health officer, and then also take guidance from state and federal guidelines. So we don't do anything that's outside of what others are recommending for us to do. And I just want to also say we are going to be going through a period of some change, over the next weeks and months, and with respect to all things related to COVID as the pandemic changes. And that's really, honestly, nothing new. But you'll expect to get a lot of guidance from our experts, and that'll be published in the ways that we normally do. Lisa, there's some other questions. I think you already answered this, but let's just make sure that we answer this specifically. Are variants a serious threat to vaccinated people?
Yeah, that's a really important question. And I think the real answer to that question is that we don't know. But I'll speculate a little bit at that based on the data that we have so far, both from the big clinical trial of international part of the trial of the J&J vaccine and the laboratory data that we have on how well antibodies from vaccinated people neutralize the variant viruses. I think we are going to continue to have efficacy against the variants. And hopefully it will be enough to prevent severe disease, as was seen in the J&J trial. But the virus, if it continues to circulate, is going to continue to change, and we may need to get vaccinated again with updated vaccines. I think that is possible to continue having high levels of protection. So I think stay tuned. We are all concerned about the variants, but with high levels of vaccination and what we're doing now, we are definitely seeing some improvements. So we'll be following it closely.
And Lisa, one more question for you. This is a great question from the crowd. Are there any data yet on the population who have missed their second dose, and what are the implications of that?
Yeah, so no data as yet that I'm aware of. So in the clinical trials, they were very motivated volunteers, and just about everybody got their second dose and got it on time. So we don't have a lot of data from the clinical trials about that. But in the real world, there's all kinds of things that interrupt people from getting their second doses. However, based on what we know from other vaccines, it's probably not going to be a problem if people get their second doses late, even if they're, outside the, so the recommended time is 3 weeks for Pfizer, 4 weeks for Moderna. If you can't hit that, we try to hit 6 weeks. But even if you're outside of that, the vaccines are probably going to work fine. And they're probably going to give people high levels of protection, but it will be delayed for that person. They won't, get that higher level of protection until they get their next dose. So I'm not super worried about that. But I do think we'll, have to keep finding people and trying to get them their second doses of the vaccine if they didn't have it on time. There's a lot of benefit from the first dose of the vaccine, so we don't want people to say, well, I'm not going to vaccinate someone because I'm worried that maybe we won't be able to get them their second dose. We should try to figure out how that's going to happen, but we should, keep vaccinating with first doses and then, just keep working on those second doses.
And great that we have the J&J vaccine for people that we're really worried won't get their second dose. That's a good option for us.
I think the J&J vaccine will provide a number of opportunities, and so we're excited to have as many options as possible.
Great. There's one question, and I wonder if there's somebody from our IT team on the call. There's somebody who notes that lately it seems like many outside agencies can't open our secure emails even with the one-time password, and if there are any suggestions for that. And if we don't have somebody from IT who can address that, we'll try to address it through the daily communication. I'll pause for 1 minute. Okay, we'll just address it through daily communication. Oh, Nita's on. Okay, Nita, what say you about this issue? And she's probably trying to unmute. Christina or Brent, can we help her?
Can you all hear me?
Yes, we can hear you. Thank you.
Yeah. So secure emails, it depends on which, the emails are run by the Department of Technology on the city side, and that is different from the DPHIT. And then UC emails that are secure are managed by the protections of UCSF. And so it depends on whether you are sending an email that's secure from the UC side or from the DPH side. So you would have to put in a ticket to the relevant group that is involved in your email. So if you're UCIT and you're finding that people are having difficulties, you can certainly talk with the folks on UCIT and their emails. Their secure processes involve creating a password for both of these. They involve creating a secure password and account for why you need to log in. And then if people forget how to do that, then there's usually a message on there of how they can call UCIT or the city's IT to be able to reset their password to read a secure message. So we'd have to know more about which side this is coming from, and then who you're trying to send it to. That would be my recommendations.
Okay, great. Thank you, Nita. So submit a ticket to the appropriate IT group. So we are 2 minutes over. I just want to say one last thing, that the Research and Academic Building there will be a virtual town hall on March 17th from 12 to 1. We'll make sure to put that information about that in the daily communication. And then I just want to say thank you so much to everybody for participating. This is a great way to stay connected while we still need to be virtual. So thank you to our presenters. Thank you to all of you for participating, and thank you for taking care of our patients every day. Have a great day, and we'll see you next month. Thank you.